The following podcast is part of a certified educational activity titled Breaking New Ground in the Treatment of COPD, Exploring the Potential Use of Targeted Biologic Therapy in Patients with Evidence of Type 2 Inflammation. Access the entire activity and complete the post-test at peerview.com/BAU860. Downloadable slides and practice aids are also available.
Hello, this is Dr. Surya Bhatt from the University of Alabama at Birmingham. Welcome to this unique activity that will explore the role of type 2 inflammation in COPD and the potential use and clinical implications of targeted therapy in appropriate patients with COPD. Our goals for today are to expand your knowledge of the role of type 2 inflammation in COPD, to improve your ability to assess the latest trial data regarding efficacy and safety of targeted therapies for COPD and their clinical implications, to equip you with strategies for identifying patients with COPD who may potentially benefit from the use of targeted treatment, and to provide you with guidance on integrating targeted therapy into clinical practice for patients with COPD as appropriate. So let's start with a little bit of background as to how big the problem of COPD is. The WHO estimates that by 2060, more than 5.4 million deaths per year will be attributable to COPD and related coexisting conditions. And this is an important problem given the aging population. And it's not just mortality that's important, but the course of COPD is punctuated with acute exacerbations, which regardless of severity, whether they're moderate and treated at home with steroids and antibiotics, or if they're severe resulting in ER visits or hospitalizations, can lead to poorer quality of life, increased risk of future hospitalizations, and increased risk of death. And despite a lot of treatments currently being available, the disease burden remains very high for a substantial majority of the patients. And COPD has long been recognized as involving an amplified innate immune response, but now there's growing understanding of the intricate immune mechanisms involved in the pathogenesis of COPD, and an increasing understanding that some patients have predominant type 2 inflammation. So there is a specific need for treatments that target this underlying type 2 inflammation that's present in about 20 to 40% of patients with COPD.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an independent medical education grant from Regeneron Pharmaceuticals Incorporated and Sanofi.
Now, very broadly, COPD is characterized by increased inflammation with infiltration of the lung tissue and airways and the lung parenchyma, as well as the pulmonary vessels with neutrophils, lymphocytes, and macrophages. And these inflammatory cells, together with epithelial cells and other structural cells, can release a variety of inflammatory mediators that can further attract more immune cells and then go on in a cascade-like fashion, resulting in further perpetuation of the inflammatory process. And they can also induce some structural changes via the release of growth factors. And although neutrophilic inflammation has always been traditionally been thought of as the most important mechanism in the pathogenesis of COPD, we are now recognizing that some patients have an inflammatory pattern with increased eosinophils and more broadly with type 2 inflammation, similar to what we've long recognized to be the case in asthma. So this is a figure that shows the inflammatory cascade involved. It's much more complicated than this, but very simplistically, in response to a variety of insults such as viruses, bacteria, cigarette smoke, oxidative stress, the airway epithelium can release first-line cytokines, which are called alarmins, and these are predominantly interleukin-33 and thymic stromal lymphopoietin, or TSLP. These can then stimulate dendritic cells to help Th-naive cells to differentiate into Th2 cells, or they can directly stimulate innate lymphoid cells type 2, or they can directly stimulate eosinophils, all three cell types, to release type 2 inflammatory cytokines. Interleukin-5 can further cause eosinophil activation in the bone marrow and maturation, and then release into the bloodstream, which can then perpetuate a cycle of type 2 related interleukin-5 predominant inflammatory cascade. IL-4 and IL-13 have more broad mechanisms of actions. They can stimulate the basal cells to release goblet cells and increase mucus formation. They can cause macrophages to polarize into the bad macrophages instead of the good M1 macrophages into the bad M2 macrophages, and hence cause peribronchial fibrosis. They can stimulate B cell class switching to produce more IgE. They can cause more inflammatory upregulation of type 2 cytokines via a circular pathway. They can stimulate smooth muscle cells to have increased contractility. And IL-13 is especially important in mucus production from the epithelium. So the predominant cytokines, to summarize, are IL-4, IL-5, IL-13, and overall the Th2 cells. And there are now biologics looking at targeting these specific cytokines. The alarmins are being targeted by anti-IL-3 antibodies or by the blockers of the receptor for IL-33, such as ST2. The type 2 cytokines are being targeted by IL-5 monoclonal antibodies, as well as antibodies against the shared receptor for IL-4 and IL-13, which is an IL-4 receptor. The IL-5 pathway specifically drives eosinophil maturation and survival, whereas the IL-4 and IL-13 pathways increase fractional exhaled nitric oxide, so which can be easily measured externally. And also more broadly, they promote eosinophilic activation and inflammation pathways. And these inflammatory cells and cytokines are believed to be critical in the pathogenesis of COPD now, especially in those with predominant type 2 inflammation, resulting in airway hyperreactivity, impairment of epithelial barrier function, peribronchial fibrosis, and hence airway remodeling, goblet cell hyperplasia, increased MUC5A and mucus production, mucociliary dysfunction, and all of these as a consequence cause lung function decline. And this evidence of type 2 inflammation is seen in about 20 to 40% of patients with COPD. And the range is a little broad because it depends on what kind of tissue you're examining. It could be in the form of blood eosinophils, it could be in the form of sputum eosinophils, or airway tissue or bronchoalveolar lavage. So the closer you go to the airway, seems like the percentage of patients affected by type 2 inflammation seems to be higher. But with the more easily measurable blood eosinophils, 20% or slightly higher than that seem to be having predominant type 2 inflammation. And there is also evidence that people with type 2 inflammation may have a better response to anti-inflammatory therapy. Now, we already know that with inhaled corticosteroids. And now with targeted biologics such as dupilumab, type 2 inflammation has now become a specific target in patients with COPD. And now let's look at a brief 3D animated video clip that illustrates the role of type 2 inflammation in COPD.
Type 2 inflammation is driven by both the adaptive and innate arms of the immune system and underpins the pathophysiology of several chronic upper and lower airway diseases, including asthma, chronic obstructive pulmonary disease or COPD, chronic rhinosinusitis with nasal polyps, and allergic rhinitis. Some studies have shown ranges of 20% to 40% of patients with COPD may have type 2 inflammation, which may increase exacerbation risk. Mediators of type 2 inflammation include eosinophils, mast cells, Th2 cells that produce the cytokines IL-4, IL-5, and IL-13, ILC2s, and IgE producing B cells. During an immune response, IL-4 and IL-13 play an important role in the class switching of B cells to produce IgE and drive the trafficking of eosinophils to sites of inflammation. Mast cell proliferation is promoted by IL-13. IL-5 mediates the differentiation of eosinophils in bone marrow. In some patients with COPD, eosinophils trafficked by IL-4 and IL-13 can be recruited to the lungs, contributing to airway remodeling and parenchymal destruction. Airway remodeling can lead to airflow limitation, resulting in symptoms such as shortness of breath, and increased mucus production, which obstructs the airways and makes it more difficult to breathe. Parenchymal destruction leads to reduced surface area for gas exchange and decreased lung elasticity, making it challenging for the lungs to efficiently expand and contract during breathing.
A variety of drugs have been tested targeting these type 2 inflammatory pathways, and the first biologic that was tested in COPD was mepolizumab, which is a monoclonal antibody against IL-5, and this was in the form of the METRIX and METREO phase 3 trials, and they had a variable effect on exacerbation reduction, but there was some post hoc analysis which suggested and gave us some lessons about which kind of patients may potentially respond. Overall, the metrics study was not successful in decreasing exacerbation frequency, whereas the Metreo study had a 20% reduction in exacerbation frequency. The difference being in Metreo, patients were enrolled if they had a screening blood eosinophil count of at least 150 or a historic, meaning within the past 12 months, eosinophil count of 300. In METRICS, patients were stratified whether they had this criteria of high eosinophils or not, but then all comers were taken in. And then in a pooled analysis of this predominant type 2 inflammation or predominant eosinophilic inflammation, there was again a 20% reduction in exacerbation frequency. And in post hoc analysis, it seemed that as we went above from 150 to 300 to 500, the higher the eosinophil count, there was a general trend toward a greater effect of mepolizumab for the reduction of exacerbations. And there is now a recently completed phase 3 trial looking at a higher eosinophil count of 300 as the inclusion criterion in the setting of frequent exacerbations as well as being on triple therapy. It's also important to note that in these two mepolizumab trials, there was no improvement in secondary outcomes such as lung function and quality of life. The second biologic that was tested was an anti-IL-5 receptor biologic in the form of benralizumab. And again, here the Galathea and Terranova studies included patients with high exacerbation risk in the form of at least 2 moderate and 1 severe exacerbation, just like the mepolizumab studies did. But the eosinophil threshold for inclusion was set at 220 cells per microliter. And a variety of doses were tested in both these trials, and overall there was no significant reduction in exacerbation frequency, regardless of what dose was used. Of course, when a trial fails, we usually look at post hoc analysis to see if there are subgroups that may respond better. And the authors of this study went back and looked at all the data that they had, and they found that if you had a combination of eosinophils greater than 220, FEV1 less than 40%, and bronchodilator response in the form of FEV1 response greater than 15%, then there was a significant improvement in exacerbation frequency to the tune of 30% reduction in exacerbation frequency. So there are now ongoing phase 3 trials with a higher inclusion criterion for eosinophil counts of 300, which are likely to be reported sometime soon. So despite all these exciting advances in biologics, we are very aware that there are significant shortcomings to the existing therapies. A substantial number of patients with moderate to severe airflow obstruction continue to suffer from exacerbations. Even those who are optimized on triple inhale therapy, about 50% of them continue to suffer with exacerbations. So it's very clear that the current maintenance inhaled therapies do not specifically target these type 2 inflammatory mediators and do not really offer much benefit for those people who are continuing to exacerbate. So with the advances in our understanding of the immunopathogenesis of COPD, I think there is a move now to not just phenotype patients based on clinical features, but also to endotype them using the biologic information derived from understanding of the immunologic pathways. So in combination, I think it's very important to both endotype patients based on the biologic pathway involved and phenotype the patients, such as classifying them into frequent exacerbators versus not. And in combination, this information can be used to make treatment decisions. And how do we identify these endotypes? So there are several emerging biomarkers to identify these subgroups within this very heterogeneous condition that is COPD. The most easily accessible and useful biomarker is perhaps the blood eosinophil count. It is predictive of enhanced response to corticosteroids. And now with the Boreas and Notus studies and dupilumab, which is approved for clinical use, this is also very predictive of response to anti-IL-4 and anti-IL-13 therapy. Fractional exhaled nitric oxide is an indirect marker for enhanced IL-13 activity, and although this is not widely clinically available, its use is increasingly being seen, especially in practices that have a high number of asthma patients, and hopefully for COPD also it will be used, as this is a good marker to predict both response to inhaled corticosteroids as well as to biologics. Periostin is another biomarker which is not really made it to prime time. This may be elevated in some patients with COPD, but I think we need more studies to understand its full potential. IgE, if it's elevated, has been associated with both exacerbations as well as lung function decline, but again, not used frequently as a biomarker, and we need more studies to understand specific cutoffs and how good it is for prediction of these important clinical outcomes. So blood eosinophils clearly seem like the most accessible and easy biomarker, and the data is quite strong. So if you have low blood eosinophil counts, less than 100, then the response to inhaled corticosteroids is practically absent. But if you're between 100 to 300, the response to inhaled corticosteroids significantly increases, and above 300, it definitely is very pronounced. And then similarly, although lower cutoffs have not been tested, seems like the cutoff of 300 seems to be the magic number in COPD for response to biologics, and this is demonstrated in the Boreas and Notice studies for dupilumab. So I think we have, in summary, a big understanding now of how all these cytokines are important: IL-4, IL-13, and IL-5. IL-4 and IL-13 seem to have a much broader effect on the type 2 pathways than IL-5 alone, which is predominantly important for eosinophil differentiation and survival. IL-4 is important for Th2 cell differentiation, and then there is an overlap between IL-4 and IL-13 for goblet cell hyperplasia, mucociliary dysfunction and excess mucus production, collagen deposition and smooth muscle contractility as well as proliferation, and then a variety of immunologic effects such as B cell class switching, increased IgE production, mast cell degranulation, and release of stimulants that can again further stimulate type 2 inflammation, peribronchial fibrosis and airway remodeling, and then activation of macrophages to the bad M2 type, and then also overall further eosinophil recruitment and trafficking, so setting off a cascade of type 2 inflammatory events. Identifying these patients in practice is, however, quite difficult if you don't use the biomarkers. We know that if you have lower lung function, although it's not a one-to-one relationship, patients with lower lung function tend to have more frequent exacerbations than those with milder disease, but a lot of patients with mild disease also have frequent exacerbations. So we shouldn't really rely just on lung function. Symptom burden can be a predictor. Having high shortness of breath, such as on the MMRC dyspnea scale, a lot of respiratory symptoms, such as on the COPD assessment test score, can predict future exacerbations, but again is not specific enough. And I think we need to have a low threshold and specifically ask these questions to discern how many exacerbations a patient is having. And then there are some structural risk factors such as bronchiectasis. Some suggestion that poor mucus clearance when measurable can also be a risk factor for exacerbations. And then there's data to suggest that reduced microbiome diversity is a harbinger of future exacerbations, immunoglobulin deficiency. And then there are a variety of under-recognized and unrecognized etiologies such as gastroesophageal reflux, vocal cord dysfunction, expiratory central airway collapse, or tracheomalacia. And then ultimately, I think all these are clinical pointers, but I think the best risk factor or the best easily measurable risk factors are: one, a previous history of exacerbations, which is a clinical risk factor. And then you can also measure blood eosinophil counts and, if possible, sputum eosinophil counts, which are pretty strong risk factors for future exacerbations. I think most of us are familiar with the GOLD ABE assessment tool, E standing for exacerbations. If you have 2 or more moderate exacerbations or 1 or more severe exacerbation leading to hospitalization, that places patients in the high exacerbation risk category. The initial treatment algorithm, as recommended by GOLD for these patients, is to start with dual LAMA-LABA therapy. And if the eosinophils counts is greater than 300, then straight away going to triple therapy in the form of LAMA, LABA, and ICS. Or if they're in the gray zone of 100 to 300, then starting LAMA, LABA first. And if they continue to have exacerbations, then going to triple therapy. Now, I think we need a slight change in the treatment algorithm. If they continue to have exacerbations on triple therapy, the previous recommendation was to either try roflumilast, which is especially beneficial in those with low lung function of FEV1 less than 50% and those with chronic bronchitis, or to try azithromycin, which seems to work better in former smokers and has minimal effect in active smokers. And now with the recently approved dupilumab for predominant type 2 inflammation, there needs to be another consideration after triple therapy for those with high blood eosinophil counts and uncontrolled symptoms and exacerbations. Dupilumab seems to be a good alternative. With all these new advances and the increasing treatment options, I think it's very important to have a shared decision making with our patients, provide all the facts, the pros and the cons to the patients, make sure that we appreciate their values and preferences given the different modalities of action and the different modalities of administration, and then come to a shared decision about what's the best option for a given patient in front of us. Thank you.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an independent medical education grant from Regeneron Pharmaceuticals Incorporated and Sanofi. To access all materials for this activity, visit peerview.com/BAU860.